Dr. Vikram called me about to talk about real world evidence. I think it's important to incorporate topics like real world evidence, especially when we are talking about research in India. Uh, Multiple things which are developed in high income countries, like intensive therapies like immunotherapy or intensive leukemia protocols or intensive lymphoma protocols, unfortunately, due to limited resources, cannot be administered in India. And this is the time we need to think about what we can do for our patients in this limited resources and how we can improve the outcomes of these patients. So today I would be taking an example of palliative chemotherapy in head and neck cancer and would explain that how you can improve outcomes by doing research and how this the intervention which you are using could be made what I would say user friendly in the in the terms that it would be more accessible to patients and it won't cause a lot of financial toxicity, which is a consideration in our country, and it would still have efficacy. So this is a design of a study called Keynote 048. Uh, what what the study was? The study was done and was completed in 2019, and it got presented in 19 and got published in Lancet. This is a study of first line chemotherapy in head and neck squamous cell carcinoma. So patients who don't have any curative potential left, in whom we need to give palliative therapies, they were divided into these three arms. A drug called pembrolizumab was given. This is a checkpoint inhibitor, what we would also known as immunotherapy drug. Pembrolizumab with chemotherapy, and the standard of care, which was at that time, which was called the extreme regimen, which was a targeted therapy, cetuximab plus combination chemotherapy with cetuximab continuing for a till the patient develops progression or has intolerable side effects. In all three arms, the maintenance here there was no chemotherapy, so pembrolizumab itself would continue. Here also pembrolizumab post induction would continue as maintenance till patient develops either intolerable side effects or progression of disease. What it gave is the 2 year outcomes with this increased to 40%. The survival of 2 year was increased to 40% as opposed to 22% what we used to achieve with cetuximab. And this was statistically significant. And still, after this time, pembrolizumab or a combination of pembrolizumab plus chemotherapy has become standard of care. Now, quite a few of you may not be medical oncologists or may not be treating head and neck. So let me put in perspective, what does this mean? This is the slide of curatively treated. So the previously patients were palliatively treated, which means there was no hope of cure. These were slides of patients who were curatively treated. All of them have undergone surgery. This is again a study done from Tata. And they received after surgery either radiation or chemoradiation. I wanted to focus on what would happen at 24 months. And you could see that at 24 months, the outcome was around 40%. We would say just higher than 40%, 40 to 40%. So what I'm trying to show is that in curatively treated patients who were undergone surgery, who are undergone radiotherapy, the 2 year outcomes was around 45%. Here we are talking about palliatively treated patients who have already have undergone surgery, have undergone radiation, and they don't have any curative potential local therapy option left, in whom when we give palliative therapy, the outcomes were nearly similar. And that was an incredible achievement. The problem is the state of palliative care therapy in India is very different. Pembrolizumab costs 3 lakhs in Indian rupees per cycle. It needs to be given every 3 weeks and it continues till the disease progresses. So a treatment of 6 months will cost you anywhere between 18 to 21 lakh only for the drug itself. The combination of pembro plus chemo gives a complication rate of 85% and with severe complication rates of 45%. So if you add up the cost of complications with the cost of doctor visits and the budget goes to well above in 6 months around 40 lakhs. Now, we need to understand the socio-economic condition of patients who develop head and neck cancer in India. Most of them are farmers or they would be laborers. They come from the low poor socioeconomic strata. The accessibility and affordability to pembrolizumab or to drugs like cetuximab is less than 1%. Most of them are so poor that they cannot even they don't even want to come to the hospital because there's multiple visits to hospitals. These are mainly daily wages. So this multiple visits to hospitals deprives them of the income which is required for them to support themselves and their family. So at one end, we have the Western data showing that pembrolizumab plus chemotherapy improves outcome. It improves outcome as much as nearly we could achieve in a curative setting. Fantastic results, but high side effects. Intravenous therapies need to be given regularly and multiple hospital visits, and overall, and most importantly, not affordable to most of our patients. This is just a data to stress upon what is the affordability of these therapies in India. And I want you to focus on the this part, which is head and neck cancer. This is the data of 15,000 patients in which we wanted to see how much the immunotherapy could be afforded by the patients. And you could see that in 2016, only 0.25% of the patients in head and neck cancer could afford. This number has steadily improved. Remember, in Tata, 40% of patients are of private category. So when if I put this in terms of general category, this number would come down even below. So what I'm trying to suggest here, or what I'm trying to make a point here is that you need to have a look at your own data when you want to do studies in real world. Just because something comes from a high income country or something comes which is very promising, it necessarily is not applicable in your setting. And you need to have that common sense whether these things could be applicable in your settings or not. Clearly, the data suggests that use of pembrolizumab or even for that matter cetuximab in a country like India or for that matter any low and middle income country, it's just not accessible. We can't have a standard of care which is affordable by less than 5% of our patients. Now, another thing which you need to understand is we're talking about palliatively treated patients. One of the important thing is we always look at whether it improves lifespan, whether it improves lifespan or not. When you want to do studies in real world, it's important to also look at patients and ask them what they want. And this is an example of what we did. This was a simple questionnaire which we made because there was no data. Commonly, we would get criticized from our radiation colleagues and surgical oncology colleagues that the therapies which you give cannot improve outcomes for more than 2 months, 4 months, or have minuscule improvements outcome. We don't think the patient wants those therapies. They can be sent home. So this dilemma is there, and there's very limited literature in globally whether what patient wants, and hence we actually made a pro forma and validated and then used this in 200 consecutive patients to capture their expectations and preferences. And it came as a surprise. It's important to do the studies in your settings in your patients, and multiple times things which are you would see that with the change in socio-economic pattern, with the change in the kind of atmosphere around, the things are different. The primary expectation of a patient was prolongation of life in 41%. 35% wanted both life increment with symptom relief, and 24% only said, okay, only if symptom relief is there, which means that 3/4 of your patients who come to your OPD have that expectation that the doctor will give me some therapy which will increase my lifespan and would also provide symptom relief. So the belief which my colleagues from surgery department, radiation department had that for small minuscule benefits, the patients don't want therapy was not correct. And it's important to look at data for such kind of real world data because this data give you an idea what the patient wants. In this data also came that the patient wanted something oral and something which they can take at home easily. So what we did at Tata in a real world setting, which would help us. Giving cetuximab was out of question, though it became the standard of care from 2006. Even coming for multiple visits for intravenous therapy, most of our patients were not willing to come. We devised an oral therapy. And we devised an oral therapy which was based on simple principles. First, the drug should be effective. The drug should be such that there's no cold chain requirement. Many patients come from rural, so they can't maintain a cold chain. And they should be on the WHO essential list. So not only in India, if this therapy gets developed, even in any country in the world, these drugs will be available and would be useful. We started using metronomic chemotherapy, that is therapy in low doses, which is around one tenth of the doses of what are normally administered in clinics, because it's seen that in these low doses, if you do continuous therapy, patients benefit. Didn't have much data, so we did a retrospective analysis. And you could say this data was only in 18 patients. What we saw in 18 patients was that this therapy, which was oral, could be tolerated by patients and could provide benefit to nearly 66% of our patients and had a reasonably good PFS and OS. We thought, okay, before we take any step, we did a small study, a small retrospective analysis for giving patients on compassionate ground who were not willing to take IV. This we expanded this to cohort to 64 patients over the next year. What we saw that yes, with this therapy, what was seen in the small cohort got stamped or was reproducible in a larger cohort. The patients were benefiting with this kind of therapy. Now, as was rightly pointed out by the speaker here, when such things come, you need to go for go for a randomized trial. And we actually planned a randomized trial, a small randomized trial of 110 patients. 55 received intravenous therapy and 55 refused metronomic therapy. And what we saw that metronomic chemotherapy was better than intravenous therapy, both in terms of disease controlling and improvement in lifespan. And this we published in 2015. Now, this was a phase 2. We didn't stop there. We thought that this is great. We have found out a therapy which is low cost, which is oral, it does not cause much adverse events, and we need to go ahead and establish it. So we, after that, did a phase 3 randomized study. This was around 450 patient phase 3 randomized study. We thought, okay, if the drugs are good, they are benefiting, they have less side effects, even if they're as good as intravenous chemotherapy, we are okay to use it in the clinic. And hence, we developed a non-inferiority design. And this was accepted as an ASCO oral in 2020. And simple design, intravenous cisplatin versus oral metronomic therapy. What we saw is that there is one more thing which I would want to show you in this picture is most of our patients, in spite of this disease with oral cavity, come with such huge lesions, and which have gone up to the skull base, has gone up to the reached up to the skin, and have got to most of the fissures in these areas. And in these patients, providing some treatment and helping them actually is very satisfying as a doctor. So what we saw that use of oral metronomic chemotherapy was non-inferior, which was it proved its non-inferiority. In fact, it was better than the intravenous therapy. It not only that, as this therapy was oral, it has less side effects. It required less hospital visits. For intravenous chemotherapy, you need to come every 3 weekly. With you would have at least 30-40% side effects, so the number of visits increases. The number of visits in oral therapy actually go down. It actually improved the quality of life of this of the patients. And what we also saw that we didn't achieve as great results as with extreme kind of therapy, in which addition of cetuximab. But if you see the results which we achieved were very similar to the results which we achieved with chemotherapy regimens. And if you look at the side effects, this is only 20% side effects, and you can look at the side effects here, which are 76 to 80%. And if you look at the cost, this is around $15 per month, and you could this cetuximab regimen, pembrolizumab regimen, cause at least, I don't know, it's more than 1,000 times the cost of these regimens per month. So what was done here was in a systematic way over 8 to 9 years we identified a problem. There was a solution from high income countries, but which was not accessible to our patients. We tried to develop a regimen which was effective. It was in a way which was culturally acceptable. It was in a way it was actually socio-economically acceptable in which the patients can be at home, have minimal hospital visits which are at like 2 months, 2 monthly apart, and they can achieve nearly similar benefit with which would be fitting to this patients. But the good thing about science is that if you have identified something, you don't stop there. We Metronomic chemotherapy, as I told you, the dose is 1/10 of the maximum tolerable dose. So that normally in clinic, if I were to use a dose of 100 mg for metronomic action, the dose would be anywhere between 1/10 to 1/3 of that dose. Now there was no model available at that time. If you wanted to redo this for other cancers, like I want to do it for gallbladder cancer, for pancreatic cancer, how would you identify a drug whether it has metronomic action? And how do you identify what dose it would have metronomic action? So this aspects become important. Just one, if you tackle one problem and you find a solution, doesn't mean that you stop working on this solution. Uh, it's- the day you stop working on the solution, the progress in that field stops. Until you get 100% outcomes or 100% satisfactory outcomes, you need to keep working on this. And this is what we did in this. We saw that a metronomic used to work well, but if the patient has previously received cisplatin therapy, it was not that great. So what we did is we made a certain modifications in the dose. We did that by getting help from a track scientist and a statistician, making a this was one of the first models which were made. It was a de-escalating model which was made to identify the metronomic dose of a drug. And along with that, we added another drug which was again an oral. To go in the principles again, it should be oral, should have less side effects, should be easily financially affordable, and should be available in most of the places in the world. We got again, by God's grace, lucky here, and we could see that even in platinum refractory patients, we got a response rate of 44%. So the drug pembrolizumab, which I had shown in platinum refractory, gives a response rate of 15%. That is 1515. We got a response rate of around 44%. And the response was pretty durable, and the time to response was quick. And this is just an example of one of the patients. You could see here that this completely disappeared. I'm sorry, you can't appreciate it. This whole mass here was actually had disappeared. And we got respectable PFS and overall survival, which are very similar to what we got in immunotherapy studies. We also saw that the patient's quality of life improved from baseline as he went on to the therapy. Now the issue was, if you could see here, this therapy was great, but even if the patient responded, in 3 months, this response was not durable. As I told you, you don't stop once you find a solution, you keep working on the solution to make it important. One of the good things about immunotherapy is, if even if only 15% of patient responds, this response is durable for a long period of time, 14 months, 18 months. The problem was, it was an attractive proposition for us to add immunotherapy alone to metronomic chemotherapy. But it would make it financially unaffordable to most of our patients because the cost would just skyrocket. And second is, there would be a chance of, with full doses of immunotherapy being given, increase in side effects. At that time, we did a good literature search, and what we found out that the, the way immunotherapy acts is by blocking the PD-1 receptor in the T cell. For the block to happen, around 70% of the receptors on the PD-1 needs to be occupied. And when you look at the pharmacodynamic data, you realize that this occupancy actually happens well at 0.1 to 3.3 milligram per kg. The dose of nivolumab is actually 3 milligram per kg, but this occupancy happens at 0.3 milligram per kg. What does that suggest? That suggests that probably by giving a dose which is one tenth of the recommended dose, there was a theoretical possibility that you may achieve a similar kind of response and benefit. And we actually use this in a few of our patients for compassionate ground who couldn't afford immunotherapy and didn't have any options of treatment left. What it showed was, it did show that use of low dose immunotherapy actually benefited our patients. This is unpublished data of around 500 oral cancers. It's seen that if you have higher PDL1 expression, the more the benefit. Most of our patients of oral cancer use tobacco, which causes inflammation, and there is higher PDL1 expression. So only 11% have the PDL1 scores at 0. Most of them have PDL1 scores which are high, which means that use of immunotherapy in our patients should give more benefit than what is seen in other countries in which the PDL1 scores are around one third, one third, and one third. With that logic, we designed a study where we took metronomic chemotherapy, which was established as a standard of care for us and in India itself, and we have been using it for last now 4 5 years, and added low doses of nivolumab to this combination. The primary endpoint was overall survival. We have finished these results, and this has got accepted for an podium presentation at ASCO, and we will be presenting this data on 6th of June. The idea here is that the way you took a problem which was, well, in India, head and neck cancer is very common. It's said that out of 100, 30 patients for males will be of head and neck cancer, and most of them will be locally advanced. So this was a very common problem, a real world problem, a problem for which there was a solution there in the Western, but which was not affordable. And I'll tell you what was the cost. So you see the cost of extreme regimen for 1 year, what it comes. This is 35 lakhs. The cost of Keynote 048, that is pembrolizumab, used to come out 61 lakhs. The cost of, if you give nivolumab alone, comes at around 48 lakhs. Pembrolizumab alone comes at around 61 lakhs. These are not the cost which a regular farmer or a dihadi worker or a daily wager is going to afford. The development of this regimen of methotrexate, darolutinib, celecoxib, low-dose nivolumab, the cost comes down annually to 3,30,000, which is well within the Ayushman Bharat scheme, where patients can be given this treatment options. Sometimes they respond with them so beautifully that even if they're palliative, you could actually go ahead and do surgery in this patient, as was done for these patients, and it could be useful. One other thing which we also did is, commonly, yesterday also Dr. Indranil pointed out that Tata does most of the studies unicentric. So at present, there is a multicentric study going on under the banner of Cancer Research Statistics Foundation. Tata is not a part of this, but you could see it's going on for, again, looking at metronomic chemotherapy as post second line therapy, again physician's choice treatment. And I'm happy that this group has picked up this therapy, because this is something which is a real problem, and you need solutions which are from the soil itself, which could help, because no one else is going to provide you those solutions unless you think about it for your patients. It's also important that we don't forget that in India, we have other issues also. There is very limited development of palliative care. There is very limited development of mental health. So it's important that along with this, such real world problems like how we can develop palliative care, what is the benefit of developing palliative, are also addressed. This is one of our studies in which got published in JNCI in 2021, where we saw the benefit of incorporation of palliative care, early palliative care in head and neck cancers, distress management in head and neck cancers. Now, metronomic, the saga in palliative looks very good. Obvious question would have been that if metronomic is so good, And I showed you that in curative setting also, patients fail so much so that curatively treated patients 60% die within first 2 years. Why not incorporate metronomic in curative setting? And yes, this has been done, and the head and neck DMG is actively doing that. In which recurrent head and neck cancers who undergo salvage surgery have been randomized to observation versus metronomic. Patients who are radically treated with CTRT upfront and have developed CR have been randomized to observation versus oral metronomic therapy. Similarly, there are studies which are going on as neoadjuvant and adjuvant metronomic also. This is the status of the study. This has been completed, and this is the negative study. This will be presented at ASCO by my colleague Dr. Chopre. And this study has finished recruitment, and within probably in the next 1 year, we'll get the results. And this is important. This kind of studies were something very cheap, affordable, effective. We need to take this up and develop, because these are the solutions which will be long lasting for our population. We need solutions which are applicable to 90 to 95% of our population, and not to 5% of the population. Uh, when I was told to take this lecture, I thought that I would talk about uh, real world evidence in a way of a story, to inspire you that if you think out of the box, if you're willing to play out of the box and work consistently on a concept, you are bound to get success, and that would benefit a lot more people than just trying to follow what the high income countries are doing, or those kind of treatments which are applicable to only 5% of the people or 7% of the people. A lot of people have funded me, and I need to thank my funders for what the work, for Dr. Kumar, Dr. Vanita, and Dr. Amit Joshi for supporting me throughout all my studies. And I need to acknowledge a lot of my colleagues who work with me in uh, at track. And I need to thank especially Dr. Vikram sir for the pharmacokinetic and dynamic profiling he has done in multiple studies, including for the metronomic therapy and even for the low dose immunotherapy.